Hello and welcome to the Calcium Masterclass series, brought to you by Shockwave and Optima Education. My name is James Spratt. I'm a professor in interventional cardiology at St George's Hospital here in London. And over the next 10 classes, we'll be taking a detailed look at all aspects of coronary arterial calcium with an expert global faculty. We will learn about the pathogenesis, impact and treatment of coronary arterial calcium. In today's Class 1, the challenges and unmet needs in coronary calcium, we'll be joined by 3 expert speakers. Here in the studio, we have Peter O'Kane. Great to see you, Peter. And you'll be talking about arterial compliance. Is it relevant? We'll later be joined remotely by Rob Riley, who'll be speaking on the unmet need in the treatment of coronary arterial calcium. But to start today, we are delighted to have with us Bobby Yeh, who's going to talk on coronary arterial calcium, prevalence, risk factors, and impact on revascularization. Hello, Bobby.
Thanks so much, James, for the kind introduction. It's really a pleasure for me to speak to the audience today. I'll be talking on coronary arterial calcium, prevalence, risk factors, and impact on revascularization. It's well known that coronary arterial calcium increases in prevalence with age and also varies by both ancestry and sex. So here we see the prevalence in a large population-based study of the prevalence of coronary calcium in women. And we can see that it really rises kind of in a linear fashion as we go up in age across all racial and ethnic groups. In addition, when we look in men, we see that the rates rise a little bit higher as well, but also continue in this linear increase in fashion with increasing age across all different ancestries. And the prevalence of coronary arterial calcification, of course, then is age and sex dependent, but it occurs in actually 90% of men and 67% of women older than age 70. So highly prevalent among the elderly population. Coronary calcification can really be thought of in 2 separate ways. The first, and I should say more broadly, vascular calcification. One is what we think of, I think, when we do coronary angiography, which is intimal calcification. And this is the type of calcification that encroaches on the lumen, is the type that you typically are seeing on your intravascular imaging. And it can be strongly associated with fibrous cap disruption, inflammation, and can lead to acute coronary obstruction and instability. Secondly, there's medial calcification. This is slightly different. This occurs deeper in the elastic lamina, results in decreased vascular compliance. It is not the type of calcification that's associated with luminal obstruction, but it can be nevertheless associated with local ischemia and development of heart failure through altered hemodynamics. So just a little bit more on intimal versus medial calcification. On the left side, intimal calcification, of course, I've just mentioned, associated with atherosclerosis and plaque vulnerability. And really, if you look at the biology of how this intimal calcification forms, it's really well understood at this point that vascular smooth muscle cells and macrophages form up a really key component of this. Secondly, it's most common in coronary arteries, and really when we think of peripheral artery vascular calcification, we're often thinking more of medial calcification, which is not the type of calcification associated with atherosclerosis, more common in the aorta. When we see that on chest x-ray, that deep elastic medial calcification, it's not associated with luminal encroachment, but does affect, and I'll speak about this a little bit later, does affect the way that the hemodynamic waveforms reflected from the pulsations in the aorta are rebounding. Here's more on the pathogenesis of intimal calcification. This is caused in the intimal layer, vascular smooth muscle cells, of course, first initiate this process through what's thought to be apoptosis. And actually the apoptosis of these vascular smooth muscle cells can then result in microcalcifications. Similar finding happens with macrophages. Punctate calcification arises from macrophage apoptosis, usually within the lipid core of atherosclerotic plaque. So it turns out that the risk factors for coronary artery calcification in the intimal and the media are quite different. Intimal calcification is associated with the risk factors that we think of when we think of coronary atherosclerosis: advanced age, diabetes, dyslipidemia, hypertension, male sex, and cigarette smoking. On the other hand, medial calcification, for the most part, is not associated with many of those factors. It does progress with advancing age, but really the strongest predictor or strongest risk factor for medial calcification is renal dysfunction, particularly the duration that a patient has been on dialysis. Here's just honing in a little bit on the microscopic level. So vascular smooth muscle cells actually have an osteoblast-like function within the cells. They can become dysregulated and start unleashing and actually increasing calcification in association with the necrotic core of atherosclerotic plaque. And then macrophage foam cells can have an osteoclast-like activity, but again, their apoptosis and dysregulation can lead to increased vascular calcification. So what does this look like histologically? Well, it turns out that the calcification generally forms at the edges of the necrotic core and forms in sheets. And you can see this here in these pictures, these sheets of calcification in association with NC, stands for necrotic core, right around atherosclerotic plaque. But these sheets can actually develop breaks. So nodular calcification can occur when these sheets fragment, and then actually these calcifications can erupt into the lumen. So sometimes these eruptions are not associated with acute coronary syndromes, but they can be. So erosive calcification can actually then be associated with thrombus. And I think an OCT has really helped better elucidate the pathophysiology of erosive nodular calcification and its impact on cardiovascular outcomes. Here's just some more pictures of medial calcification. You see this calcification is deeper. It's not associated with atherosclerotic plaque. It occurs in the elastic lamina layer. Just a tighter image of vascular calcification here occurring. And this leads to loss of the elastic recoil and the normal compliance of our arteries. And the way this manifests is you can look at a normal pulse pressure, and on the left side is systolic pressure, and then that wave is transmitted down the circulation and it's reflected back. And that reflection back actually contributes to the diastolic upholding of the diastolic pressure. When there's vascular stiffening due to medial calcification in the aorta and the peripheral arteries, we can see that the reflected waveform comes earlier, raising the systolic blood pressure and then lowering the diastolic pressure by moving that reflected waveform earlier. That leads to the wide pulse pressure that we know about, and it's becoming more well understood that this change in the reflected waveform really can contribute to things like development of heart failure and even local ischemia. So why does this all matter? Well, it matters because coronary calcification is associated with poor clinical outcomes, in particular, poor cardiovascular and coronary outcomes. So firstly, we know that coronary artery calcium volume is strongly associated with other histologic markers of risk, and that includes a necrotic core volume, plaque volume, the number of TICFAs that are found in the coronary circulation. And so all of these things are come together. So vascular calcification does come with increased markers of what we know about coronary atherosclerosis that is of elevated risk. But then looking at the actual hard outcomes in several studies, and I'll go over several of them here, patients with coronary artery calcium, we know have worse outcomes, and they have worse outcomes after PCI. This is a meta-analysis of Sedefin studies, which separated patients in those with severe lesion calcification undergoing PCI and those without severe calcification. And we know the outcomes that matter the most to patients, death or MI, are strongly elevated in those patients with more severe calcification. This is a population of patients undergoing PCI, more than double the risk in this study out to 36 months. In the Horizons AMI study, an acute coronary calcium study, you look here that the one-year outcomes among the nearly 7,000 patients enrolled were, again, much worse, more death, higher cardiac death, MI, TLR, and MACE in those patients with severe calcification compared to those with no or mild calcification. So ideally, the modern DES would improve outcomes of PCI, including in patients with coronary disease, and it looks like they did. This is a meta-analysis of 18 randomized clinical trials comparing different stent generations. And what we see here is a couple things. One is that death, MI, or vascularization rates continue to rise, and they rise particularly highly in those patients with moderate or severe calcification. We also see that second-generation stents do better than first-generation stents at improving these long-term outcomes, even among those patients with coronary calcification, but the rates are nevertheless very high, even with second-generation DES. If we look at a stent-specific outcome, so this is target lesion failure, we see a very similar phenomenon. So even though second-generation drug-eluting stents are better than first-generation drug-eluting stents in terms of their rates of target lesion failure, nevertheless, those rates continue to be high, and they're particularly high in those patients with moderate or severe coronary calcium. Here are those individual outcomes on the same study by Gedney. This meta-analysis of 18, pooled analysis of 18 randomized clinical trials. And you can see here that coronary calcium is associated with dramatically increased risk of cardiac death, as well as stent-specific outcomes of target lesion failure, target vessel MI, and ischemia-driven TLR. So in unprotected left main coronary artery disease, coronary calcium, of course, matters there too. So this is a sub-analysis of the Excel trial on those patients who had moderate or severe calcification. Actually, it was the majority that had them in the Excel trial, and those patients had higher rates of 3-year death MI or stroke, as well as 3-year death. It's important, though, that the non-inferiority or the similar outcomes between CABG and PCI were retained whether or not patients had coronary artery calcification. So we do have approaches that these can be treated. The answer is not necessarily just to jump to CABG if you see coronary artery calcification, but we do know, however, that there are poor outcomes with calcification. So the question becomes, what can we do to help alleviate some of those outcomes? Here, finally, this last study, single center study that was conducted at Mount Sinai, large number of patients, coronary artery calcification, severe calcium associated with much worse. And you can look at that those curves diverge instantaneously. We know that when we see coronary calcium at the time of PCI, we know that we're in for a tougher intervention with higher rates of death or MI at the start. And then those curves continue to separate over time, going out to 1 year. So how does coronary calcium then contribute to these poor outcomes? Well, one possibility is that we know that coronary calcium makes stent expansion difficult. It certainly makes circumferential stent expansion more challenging as well. The greater the arc length and thickness of the calcium, the greater the likelihood of stent under expansion here. You can see in this meta-regression sort of curve here. And stent under expansion, we know, is associated with an increased risk in ischemic events at 1 year. So there's just some IVUS examples of how this happens. You see nodular and eccentric calcium on the left side of the screen. And this type of calcium is associated with suboptimal stent expansion. And it's seen in up to 50% of stents deployed in calcific lesions currently. So this is just what it would look like without calcium. We can see this nice circumferential expansion of a balloon in the middle of this narrowed artery. However, when we have eccentric calcium, sometimes nodular calcium in particular, can lead the balloon to not expand circumferentially, and the resulting is the stent placed with a D shape that can be suboptimally expanded. So in conclusion, coronary calcium increases with age. It varies by ancestry and sex. It grows in prevalence to the point where the vast majority of males in particular have coronary calcium at age 70. And it comes in two forms. I spoke about the intimal and the medial calcification and how they have different risk factors and different implications. Coronary calcium portends a worse prognosis for patients undergoing PCI, and its association with poor outcomes among PCI patients may be causal. It may be mediated, at least in part, by the inhibition of optimal PCI results due to under or suboptimal stent expansion. Thanks very much.
Thanks for joining us, Bobby. That was a great run through all the bad things about coronary arterial calcium. So my question to you is this: given that quite exhaustive data on increasing the adverse outcomes with increasing burden of coronary calcium, how how does that resolve itself in a patient-related discussion? First of all, how does it affect what you think? And secondly, does it change what you say to the patient?
Yeah, it's a great question, James. I think, when you see that much coronary calcium and you see a patient, you do an angiogram or coronary CT, and there is that presence there, I think it has to change the way that you think about that patient's prognosis for the long term. And so one, you counsel them about the severity of the implications of that coronary artery calcium. And I think it really behooves one to really think a lot about secondary prevention in that situation. So for me, it means I'm talking to that patient about up titration of statin therapy, et cetera, and other optimal medical therapy. But then if secondarily there's an indication for PCI, I really think it changes the way that I want to counsel that patient about PCI, and it changes the way that I want to approach that patient in the cardiac cath lab. And it's certainly true that some of that association of coronary calcium with bad outcomes is probably not causal. It's that poor risk factors come together, and it's a marker of increased risk due to other things like the sort of cardiovascular risk factors that we've seen already, age, diabetes, et cetera. But as we talked about, there are very specific stent-related outcomes that are worse in patients with coronary calcium, and those can be affected by how we treat them in the cath lab. And I think that making sure that we have optimal stent expansion, that we're imaging guided assessing stent expansion with imaging guidance is really the thing that we can do, at least acutely in a procedure, that can help hopefully obviate some of those outcomes.
Yeah, I mean, I think you made some great points there, Bobby, about taking that holistic perspective, not by pulling out a single marker of adverse outcome and saying, well, it's all about this. And I don't think that's what we're suggesting. Clearly, you can't disentangle coronary arterial calcium from age. Of course, that's maybe the biggest associative thing. You can't reasonably adjust for that. But having said that, we do have a mechanistic rationale for adverse outcome, particularly in PCI. So my question is, if you have somebody that has a good indication of a revasc and a high burden of coronary arterial calcium, would that bias you to a particular mode of revasc? Or if it wouldn't, from a percutaneous perspective, do you think that there is an emerging rationale for some subspecialty expertise in this area?
Yeah. As we saw in the Excel trial, the presence of coronary artery calcium didn't then lead to favoring one treatment arm versus the other. So I suspect that coronary artery calcium is a bad actor, and at least in my mind, doesn't in and of itself point me to one particular treatment modality, whether it's surgery or PCI, than the other. There are probably other factors that would drive that for me, including and not limited to the diffuseness of coronary artery disease as measured by something like the syntax score, but as well as the patient's own comorbidities, and their preferences, which might drive one to a more of a non-invasive approach with PCI. Now, your second question about whether or not there should be specific expertise, I think in many ways there probably should have been already, and there is in the community. Our technologies for coronary artery calcification, like rotational orbital atherectomy traditionally, really were probably better performed or more comfortably performed in expert hands. And I think it may remain as such. I think that shockwave technology is an exciting technology, in part because it is a democratizing technology. And I'm sure that there are going to be other talks during the session that goes into it, but it is the usual sort of balloon tech that we are comfortable with, more so than I think many operators are in the community with rotational orbital atherectomy. So I do think that there should be subspecialty in complex coronary intervention. To some extent, coronary artery calcification in and of itself, with the help of a technology like shockwave, may be more democratized than in previous years.
Yeah, and I think that's an excellent answer, Bobby, and I particularly like the democratization of treatment of coronary arterial calcium, because listen, let's not kid ourselves. It's not that it's rare or unusual to find patients with significant coronary calcium or lesions that don't immediately dissolve at the first NC balloon. So we're lucky that Peter is in the room here, and Peter O'Kane, who I'm sure you know, is a is a very strong advocate for imaging, and I think all of us have struggled over the years to try and integrate imaging into what is standard practice. So I guess my question to you, Peter, and in turn to Bobby is, where does imaging fit into this? Is it kind of, if we're going to democratize intravascular lithotripsy and therefore the treatment of coronary arterial calcium, do we just hand it to low volume operators and say, well, it's just balloon, wire balloon stent, just a different balloon?
I think it's a great question, and I guess in this whole session, it's a really fundamental, actually, question to ask. Just a great talk from Bobby, just to re-emphasize that. But in terms of, that's always been my concern in this situation, is that when you look at the data, clearly underutilization of calcium modification techniques is associated with poorer outcome in this association of calcific disease. But you have a device which is easier to use and more simple. But the problem is there's a learning curve, I think, in dealing with calcium, and that's why you're suggesting subspecialization. And I think if you jump to calcification techniques too soon without that learning curve or without the ability to image, and a lot of people who perhaps just stick to their balloon technologies don't want to image to prolong the case, I think there are risks involved. And I think with appropriate training, it's probably okay. But I think we have to have people who are ready for that training and not just willing just to use it as a simple device. Because I think you can get it wrong. You can use IVL when it's not necessary, or you may use it inappropriately. And also, without imaging, you haven't really got the good treatment goal. And I think that's really the key, is where do you start the case, where do you stop the case? And should you continue going with high-pressure ballooning if you've got a slight under-expansion of a stent, or do you just accept that the vessel's so calcified and you can't change the compliance too much? You just have to settle for that final result. And I think that is an incredible skill to learn, and we're all learning it, actually, on a day-to-day basis. So that's my major concern with the democratization of a technique that everyone can use.
Yeah, and that's a great answer. And so I'll finish, Bobby, with a further question to you, because we're at the start of this journey with calcium modification. And I think actually, kudos to Shockwave for, doing this educational program with actually very little direction or oversight. It's not all about lithotripsy. We want to engage operators who actually haven't considered coronary calcium as a problem they should engage with before because of the issues you addressed, the barrier to treatment and so on. So if we wanted to make sure we engage people the right way, what we're talking about is setting standards. So would you care to speculate on the minimum standards or the minimum areas where we should be concentrating our education to actually open it up to patients? I mean, we talk about operators all the time, but what we're really saying is we want to, democratize care for patients. It's not just about operators. So what would be the minimum educational standards that we should be aspiring to achieve within this program?
Yeah, it's a great question, James, and I really liked Peter's answer as well. I think that, and we started this lecture with an understanding of epidemiology and anatomy and biology, and I think that although we are technicians to some extent, we are physicians, and we all were scientists at one point in our training, and understanding the physiology and the pathophysiology really matters. And I think if you start from the pathophysiology, it lends itself to understanding what are the standards that we need clinically. The pathophysiology, whether it's understanding what coronary calcium looks like and how it impacts those vessels, and that's through an understanding of intravascular imaging. That has to be a part of the core curriculum that we need to know about. So we need to be adept at intravascular imaging, and I don't think that the rank and file operator needs to be an expert in all modalities, but they need to be comfortable with at least one of them. So if it's IVUS, if it's OCT, pick and choose and become an expert in that. They need to be comfortable with all the different modalities of addressing calcium, and that includes atherectomy, traditional atherectomy, as well as IVL. I don't think that you can just be someone who's comfortable with IVL, not know how to do rotational atherectomy or not be comfortable with it, and become an expert. We've seen that these technologies are great partners, actually. They address different lesions, and they come together and work well together to address our most complex lesions. So those two are the core elements, and I don't want to leave out understanding physiology, IFR, FFR, the various different diastolic parameters, understanding who needs to be treated in the first place. And those are, I think, at least three of the most important elements. I mean, there are other technical, I think, aspects that we could get into that you have to run across with calcified lesions, and that includes some of the techniques that you're expert in, James, with microcatheter technique, different wires, et cetera. I think those come with experience and time. But physiology, imaging, and the different calcium modalities really are, I would say, the core basis of the curriculum that we all need to know how to do.
Yeah, and that's a great answer, Bobby. And actually, to the broader community and those listening today, that's what's going to make this field exciting. It's going to give it a depth to it and a resonance to it and a proper why to it, that actually we're not just technicians that you referred to. We're actually treating patients here. And we're understanding what we're treating, and we're aligning to the correct goals. And we're setting standards, and we're not afraid to be held to those standards. And surely all those things are what makes a career a good career. So I don't think we should be scared or running away from that. And I'd like to thank you for taking your time. I know you're on family vacation, so thank you for taking your time and sharing your expertise with us today. It's Bobby, been great to see you, and hopefully we'll get a chance to meet up again physically soon.
It's great to see you, James, and thanks for inviting me.
Pleasure. Thanks, Bobby and Peter. That was great talk, great discussion. And over to Peter, who's now going to talk to us on vascular compliance. Is it relevant?
Many thanks, James, for this kind invitation to give this talk on arterial compliance and the effect on procedural outcomes. It's a talk I probably could have given better 30 years ago as an undergraduate, but here goes. Compliance is the relationship between pressure and volume in vessels. And as this graph shows, there is a difference between arteries and veins. This graph also shows that as the pressure increases, the rate of increase in volume is restricted. And that's because of the tissues within the vessels themselves. It also shows that for veins at lower pressures, there is an increased compliance and increased capacitance in these vessels, which explains the difference between the two. And equally, as you get increased pressures in veins, they take on more of an arterial appearance, which explains why we use or can use veins in arterial graft surgery as capacitance vessels. They are both modifiable with endogenous and exogenous drugs, such as catecholamines, and also will tend to cause vasoconstriction, and also molecules which will tend to cause vasodilatation, such as nitric oxide, all acting on vascular smooth muscles. This is an important concept of stress relaxation. If you take a container and you increase the volume of fluid, then the pressure will increase to a steady state. At a point, according to the characteristics of the container, the pressure will start to fall, and this is known as stress relaxation. And it's in accordance with the law of Laplace, who was a French scientist from the 18th century. Now, in different biological systems, this will respond in different ways. So, for instance, in the bladder, where there is a large number of vascular smooth muscle cells, there is a high stress relaxation, in that as the volume increases, the pressure will reduce, and this prevents damage to the kidneys. In the arterial system, such as the aorta, however, there is a low stress relaxation, and the pressure will be maintained. This is an interesting study published in 2000. This is 46 patients divided into two groups, those with unstable and stable angina. They have treatment with PCI, and they have intravascular ultrasound at the time. Using intravascular ultrasound, they're able to measure the luminal diameter and luminal area during systole and during diastole. And from that, then also pressure was measured during both of these parts of the cardiac cycle. That allows for a distance stability index and a strain index to be calculated. And interestingly, in the group who have stable angina, there is a significant difference. So the more unstable lesions have greater compliance than the patients who have stable angina. So why is this? Well, that's because when we start to develop coronary disease, we have capacitance in the vessel, and it allows it to model in a positive way and expand so that the lumen does not become encroached, and the plaque burden will push into the tissue and expand out, except as you get more advanced coronary disease, as you can see on the very far right of this slide, you can see that the lumen does become encroached. This is also an interesting study, which is published in 1993. In this study, there was a comparison of patients with normal arteries, abnormal arteries with coronary disease, and also patients who are treated with balloon angioplasty and direct coronary atherectomy. And really the conclusion from this study is that atherosclerosis itself does change the compliance, but as you start adding in more complex lesion subsets and calcification, that has a greater effect on compliance. It makes the vessel even less distensible. And calcification is not only restricted to the intima, which is where we commonly see it in the coronary artery, but it also affects the medial aspect. And calcium can be laid down along these elastic fibers and within the elastic lamina, which is commonly where it's seen. And that can tend to increase blood pressure and become arterial stiffness, which we see a lot as we get older. And there are now ways of measuring that with reflectivity index as a marker of arterial stiffness. This is a histological slide. So the reason that this occurs is because vascular smooth muscle cells become damaged. They normally produce substances which prevent calcification, but as they die, these substances aren't produced and they calcify. And this can cause a problem. It causes a problem because it reduces compliance in the large vessels. We see it in diabetics, we see it in patients with renal failure. It's different to the intimal calcification, which you see on the left-hand side of the slide. And intimal calcification is usually not present in early atherosclerosis, but as atherosclerosis develops with erosions of plaques and plaque ruptures and then healing, that's where calcification tends to occur. And as you've seen on the previous slides, it can encroach on the lumen, and that can make our life challenging in the interventional lab. This is also an interesting study, again published in 1994, so quite a long time ago, these trials. This is in 27 patients, 58 lesions. And again, they use the similar techniques as we described before in terms of measuring compliance of vessels. And what you can see nicely in this graph is that as you get to the more calcified lesions, the compliance, as we've said before, starts to reduce. The exception to that is in the left mainstem, where because of more elasticity and fibers in this autoosteal region, you do see less change in compliance compared to other arteries. And the compliance is different in the different layers of tissue between intima, media, and adventitia. And although the adventitia is very compliant in relation to the other two, it doesn't take much, as you'll see in this next slide, to really change the compliance of the vessel overall with calcification. So if we take a normal artery like this, when you have a stent to deliver, it's actually very straightforward. Stent design obviously has really developed over the last 20 years, but even with an old stent, getting down this artery would be fairly straightforward because it gives as you push the device. In contrast, when you have this level of tortuosity and calcification, the artery is much stiffer, and it's much more challenging then to be able to push devices through because the vessel will not give. And sometimes we can strip the stents off. So this is what the kind of lesions that we're commonly dealing with when we're dealing with more advanced coronary disease in the stable angina setting. So I'd like to show you two examples, just really to conclude my discussions. The first is a case of a right coronary artery which is highly compliant. As you can see, it's an acute presentation, a soft-looking lesion in the proximal vessel. Once we wire the vessel with a standard workhorse cyan blue, there is a high degree of straightening of that artery, which is tortuous. And that can provide problems because it produces angiographic ambiguity in terms of where the lesion starts and stops. But it does make the angioplasty much more simple. So intracoronary imaging actually leads to much better analysis of understanding where the lesions are. As you can see with this OCT run, it's an extremely clean vessel from where I started the run, but there is a lesion distal. When you come to the proximal severe stenosis, you can see it's made up of mixed tissues, fibrotic mainly, and also atherogenic, atheroma. And as we come back to the proximal vessel, it then normalizes. So it's very straightforward to take our measurements of the elastic membrane so we can size our stent, and it's very straightforward to implant a stent in this situation and get a very good result. However, due to the straightening of the vessel with the stent, we do wonder about whether this will make the case prone to stent fracture. This is the final OCT showing the stent expansion. which is adequate. In this second case, it's quite a different scenario. This is the right coronary artery with lower compliance. The reason for that lower compliance is because of more advanced coronary artery disease. This is a patient who's had previous bypass surgery and a mitral valve replacement with a metallic mitral valve, as you can see. The angiographic image shows an extreme calcified vessel. So this is a more challenging case. The calcium is likely to be intimal and medial in this particular case because it's so thick. Once we wire the vessel and attempt to take balloons, they will not pass. We initially tried to rotablate this artery, but were unable to get a rotor wire down into the distal vessel, even with a microcatheter that wouldn't cross. So with a guide liner, we're then trying to advance balloons through this lesion, and the balloon does eventually go, but you can see a 3O balloon does not fully expand. So this is a case where we need some modification. I'm just about able to get a shockwave balloon in eventually, and this is IVL treatment showing better expansion, and then we're able to perform intravascular ultrasound, which does cross into the lesion and demonstrates here a heavy calcific burden with deep tissue calcification, areas of fracture following the successful IVL, and 360 and 270 degree arcs of calcification. The balloon correspondingly now expands fully, and we're in an opportunity now to place our stents. This is IVUS after we've put the stents in, but the IVUS will only go into the very proximal vessel. And this is a common experience when we have a non-compliant artery. When we put stents in, we sometimes assume that we could be able to deliver kit more easily. But in fact, that isn't the case because the compliance of the artery hasn't changed. Although we've made a greater passage within the lumen, the compliance is still very low in this case and very challenging to deliver equipment. Our final angiographic images are very satisfactory, and I think we've got through a good result here using this newer technology. Thank you very much.
So Peter, that was a great talk, and I think what I like most about that talk is I don't actually hear people talking about arterial compliance very much. I guess as a subject, you kind of learn it in physics and then you park it. And it's always quite interesting when a subject that you learned, what for you must be 5 years ago, but for me more like 30 years ago, it suddenly rears its ugly head again and you have to get your head around it. Was it a bit like that when you kind of got this topic, or some unpleasant person gave you this topic to research on?
Yeah, it was an interesting, interesting you say that, because as a undergraduate, I love physiology. It's my favorite thing. And I did understand all of the aspects of the law of Laplace and so forth and compliance. But of course, it doesn't seem relevant when you're an undergraduate. But now, when you're dealing with it every single day of the week in the cath lab, you have forgotten a lot of these principles. But of course, they're incredibly relevant. And I think we ought to be revising some of this technology and techniques in our everyday practice to actually help us understand why a vessel is non-compliant. Because I don't think we always understand it. We try the same maneuvers every single time to get over a problem, when in fact, if you understood it, then you take a different angle right from the very start. I'm sure this happens in cath labs up and down the country.
No, absolutely, Peter. And I think it's very much goal-oriented therapy. If the goal of your therapy is to stick a stent in, then you'll do things which actually probably aren't advantageous for the patient at all. And actually, one of the things we'll be talking about in some detail is the efficacy of intravascular lithotripsy and what it actually does that makes it efficacious. And we talk about modification arterial compliance. And to understand that, we have to understand what is arterial compliance. And I think there's definitely a misunderstanding around coronary calcium. Like, for example, the perception is that when we treat a calcified vessel, we're modifying the compliance of calcium. And of course, we're not. Calcium, the compliance of calcium remains the compliance of calcium after we fractured it into little bits. And my latest analogy for this is a windscreen. So a windscreen in a normal car has three components, or two components. It has a sheet of glass, and it's got two sticky bits. And the sticky bits stop the glass cutting off people's heads after the accident occurs. It means that the windscreen fractures into little shiny bits. So if you ask yourself before the windscreen breaks, which is the biggest contributor of the compliance of the overall structure, the windscreen, the sticky bits or the glass?
It was a great analogy. I'd vote for the glass.
You'd be correct. But after the windscreen breaks, what has got the biggest contributor to the compliance of the windscreen? The glass or the sticky bits?
Well, I think the sticky bits keeping the glass together.
Exactly, the sticky bits. So if you take that analogy back to the artery, after you fracture the calcium, it's the compliance of the adventitia that determines overall arterial compliance. Before you fracture the calcium, it's the calcium that determines overall arterial compliance, which shows the relationship between fractures and compliance. And that's, of course, what we measure on a level of intravascular imaging and so on.
And I think you're right, and it's evolving during the case. So as you start the case, you may be aiming for that calcium modification, but then after that, you have to then adapt. And I think that's why you can't always put a stent in after you've used IVL or rotablation or any other therapy that touches calcium. And sometimes you have to go then and attack the other tissues, maybe with a cutting balloon or a scoring balloon to modify that layer. Because the adventitia, hopefully, you won't have any effect on unless you have a complication. But it is, I think it's that understanding of you have to do different aspects for different lesions. And I think the imaging does give a big help as to where the areas of problem will be. But even with imaging, it's often the feel of the vessel. And in relation to things like tortuosity and whether you've got guide catheter support and how supportive your wire is and how distal your wire is. I think all these have such major influences on how the vessel appears and how it will perform and respond to your therapies.
And you give a great analogy in that talk about the effects on compliance, distortion with equipment passing, and how you don't get that same distortion. And that distortion that we describe adversely as wire bias or whatever is actually a very helpful thing, and it's one of the things that makes treating young patients with soft plaque very easy. But as we know, that's not the environment we're working in anymore. It's older patients with hard calcified non-compliant plaque. And I think people don't quite appreciate when you pass equipment round bends, what happens is the bend doesn't stay where it is, it's actually moving, the adventitia is distending. And when you don't get that distensibility, that's when you get things that won't pass at bends.
Yeah, and it's very hard to sometimes overcome that, even with all the equipment you may have. You may have a guide extension, you may have stiff wires, you have multiple wires, but sometimes it is very difficult to get around those sort of problems. But I think understanding that from the outset certainly should make the case more efficient and probably safer, because you're less likely to do things which are potentially going to have an adverse effect to the patient.
So let me ask you one more difficult question, Peter, seeing as we've got you here. So how do you understand that you've actually achieved that change in vessel compliance? How do you say, actually, now we are where we need to be, I can now put a stent in?
Well, I think that's the compromise and almost the holy grail, to know exactly if we've done enough in that individual patient to give them a good, durable, long-term outcome. I think you have to be pragmatic in the situation. You have to take everything into account. You obviously can go on things like the minimal luminal area if you've done that with imaging particularly. But you have to accept that if you're potentially going down the stent road, which you will in most cases, you may not be able to get a fully conformed vessel or a fully compliant vessel. You may not get a perfectly concentric stent. You may have to accept a degree of eccentricity. So I think it's understanding that and not pushing things too far, because if you go too far, you'll get a complication. And it is a challenge, and I think that's why this type of education is really important, because I think it gives everyone some insights and we all learn from each other. And it's only by doing the cases that you really understand it, I think.
Yeah, I think that's right, Peter. And I think you made another very important point, that it's not all about calcium. That you can fracture calcium and you can still get such sufficient recoil that the stent won't expand properly. Because that recoil, of course, that was the genesis behind stents in the first place. Yep. It was fibrotic recoil, and therefore we need stiff stents which resist that recoil. And that fibrotic recoil hasn't gone away, so it's not just about fracturing calcium. And if we're being very selective on the fracturing of calcium, we have to remember that there may be occasions in which we actually need to, as you say, use cutting or scoring balloons or other form of lesion preparation before we put the stent in. And I think I was getting at the kind of that we don't really have a great physiological measure of compliance.
No.
We've got surrogate endpoints, which are how well does the balloon go up? What does it look like on anatomy? Are there fractures there? But they're all surrogate markers of compliance. We don't actually have a physiological measure of compliance.
No. I think you're right. I mean, we can obviously measure the kind of vessel physiological outcome, but that won't necessarily tell us about the individual points in that vessel, and also the areas which are more liable to cause a problem for the patient to come back. And going on that first case I showed, I mean, I think there is always concern when you straighten vessels out and you do alter their compliance in the longer term with a stent. Maybe that is prone to stent fracture because, the forces, we're not really understanding the artery in terms of the three-dimensional or four-dimensional domain in which it is sitting around the heart. So I think these are really important aspects as well when we're taking on cases because, if we don't think about that ahead, it's often too late once you put the stent in.
Yeah, and as you say, it is fourth dimension because there's time there. And, we ask our engineers to test stents, and the way they set up their stent failure model is they fix one end and they move the other end X number of times till it breaks, and it will always break. It's just how many cycles it takes. So if we set up stent fracture models by stenting stiff parts of the artery, and the proximal artery is very compliant and very mobile, that may in turn be an issue. But this is, I guess, why the topic is so fascinating, that there's still so many nuances that we haven't actually solved these problems yet.
I agree. A big area for research, actually.
It is, absolutely. Well, thank you for that, Peter.
Thank you.
We're delighted to have with us Rob Riley, who'll be speaking on the unmet need in the treatment of coronary arterial calcium.
All right, again, James, thank you so much for having me. It's really an honor and a pleasure to be able to speak about this technology and some of the novel ways that it's going to be treating some calcium solutions that we simply don't have any options for up to this point. These are my disclosures. So as we've discussed time and time again, significant coronary calcium in the lesions that we're asked to treat in the cath lab has been quite prevalent for some time. This is some older studies, and we can see that in the lesions we're treating, it's almost 1 out of 3, that have significant coronary calcium. And the prevalence continues to increase because many of the risk factors continue to increase for coronary calcium. Patients are living longer, increasing prevalence of diabetes, hypertension, renal failure. And we're also doing things to patients, helping them live longer with more complex revascularization, whether it be high-risk PCI or taking care of valvular disease percutaneously that was previously untreatable, things like TAVR. And again, the prevalence of coronary calcium is obviously associated with patients with higher risk anatomy and aortic stenosis. Why is it a big deal? Well, we know that significant coronary calcium is associated with increased periprocedural major adverse events in patients undergoing PCI. You can see here in an acute coronary syndrome population, you can see that significant coronary calcium is associated with increased risk of hard endpoints, target lesion revascularization, death, MI, et cetera. We see the same thing in a stable coronary artery disease population as here. Again, the delta is significant, and these are hard clinical endpoints that patients care about. The reasons for that are multifold, some of which include many of the different things we have to do in order to prepare the vessel in order to get the stent implanted, specialty balloons, atherectomy, et cetera, which have their own complication risk, as seen on the left side of the slide. Then once we try to get the stent in, it's a very inefficient process, as you all know, setting up for atherectomy, these balloons, trying almost to dissect the vessel in order to get the stents there. Once we do finally get the stents there, they're often mangled, as you can see on the middle slide there, or they're inadequately expanded, which is a major risk factor for decreased drug delivery, which increases our risk for instant restenosis and thrombosis. So what we see is the increased risk of procedural complications, along with this risk of incomplete revascularization procedural failure, leading to this increased risk for target lesion failure and major adverse events in patients with significant calcium. So very prevalent and a big risk factor for bad events for our patients in the periprocedural time around these procedures. So what have we done over the last couple of decades in order to address some of these calcium problems? Atherectomy has really been our mainstay and really one of our only treatment options. Rotational and orbital being the two mainstays there. Laser atherectomy is there, but again, not many people use it for calcium as it's relatively inefficient compared to rotational and orbital atherectomy. We know that when atherectomy is used, as you can see here in rotational and orbital studies that have been done, we can increase the procedural success rate significantly, very similar to our non-calcified PCI success rates. We also know that when these strategies are employed correctly, we can take that delta between MACE rates for those with and without significant coronary calcium and make them non-statistically significant. So we know when we do use these strategies, we can make these procedures safer. Some of the problem is, however, though, many of these strategies are associated with complications. In particular, we think about atherectomy, we think about not being able to protect side branches, we think about distal embolization, we think about dissection. So all of these things really have led to a very low use of atherectomy and a real resistance from clinicians from using these technologies. We have had an iteration of different specialty balloons to deal with calcium as well, this being the most novel one being the Wolverine cutting balloon from Boston Scientific. But again, use patterns are relatively low. They're pretty bulky, difficult to get into these lesions at times with variable success rates. So with all this technology present, with this increased prevalence of coronary calcium, and we know that it leads to significant events for our patients during PCI procedures, we came out with the Society for Cardiovascular Angiography and Intervention came out with a calcium treatment algorithm that joins many of the other algorithms that have come forth in the last 12 to 24 months. And a big part of this algorithm is really saying we want to make sure we identify lesions with significant calcium so that we know we have to take some sort of calcium modification solution, whether it be atherectomy, IVL, et cetera. And so the first and foremost is using intravascular imaging. And while this isn't an imaging talk, we know that using imaging lowers our major adverse event rates. And part of that is recognizing certain types of lesions that need more preparation than others, a big part of that being coronary calcium. So if we're not able to get an imaging catheter down, that's your first clue, right? Your first clue that you probably need atherectomy. If we are able to get our imaging catheter down, we're looking for certain key characteristics that have been evaluated by multiple different imaging substudies at this point. And while there's a little bit of play on what the true definition of these characteristics are, the basic idea is if you see calcium with an arc of over 180, some say 270, but 180 is probably a little bit of a fair shake of things, a calcium length of over 5 millimeters or a thickness of over 0.5, these are going to be the types of lesions that are going to need some sort of special vessel preparation. So that's when we sort of go down and look at our atherectomy versus our intravascular lithotripsy. If we don't have these characteristics present, but again, you know there's calcium there by angiography, et cetera, we're going to move to our NC balloons. These are going to be lesions we're not treating with our standard semi-compliance. We're going to go to NCs. If we don't have full expansion, that's particular where we're going to use our intravascular lithotripsy. And then we're going to go on image-guided stenting and optimization at that point. However, there are some real limitations to some of the technologies that we've talked about. So in particular, deep and thick calcium, our atherectomy really only can shave and treat that superficial calcium, break up some of those superficial planes. We don't really have technology that sort of addresses this deeper calcium. So when it gets particularly thick or when it starts to involve the tunica media, we know that that happens because we know that sometimes in CTO PCI, we still have to do calcium strategies, even in the subintimal space. So we don't really have any great solutions for that yet. These calcified bifurcation lesions, as spoken about earlier, we often can't keep wire access around these side branches. And we do know, despite a lower incidence of plaque shift with atherectomy, it still happens. And we know we still can put those side branches at risk. So that's a big deal. Large vessels, right? All we really have is but maybe some of these larger specialty balloons, again, can be difficult to deliver with variable results there. We can also rely on the bias of atherectomy burrs or crowns, but again, this isn't reproducible and it's unpredictable. And instant restenosis. So in comes intravascular lithotripsy, a balloon that goes into this lesion inflated to low pressure. And again, the low pressure is key because we're not causing barotrauma like we would with an NC or a specialty balloon. Once it's inflated to low pressure, these have these expanding and collapsing vapor bubbles that cause these acoustic pressure waves to form that selectively interact with the calcium, modify the calcium. So not the normal tissue, but really this hard, calcified lesions, again, causing these microfractures in this localized field effect, both in the superficial and the deep calcium, in a way that we simply don't have any other technologies that can reproduce. These are some MicroCTs that show these microfractures that occur. And what's interesting in some of the IVUS and OCT substudies we've seen with use of this technology, we can see some overt fractures, but there's also these microfractures that lead to what is a change in the compliance of the vessel. And that's really where this technology is different. When many people ask, so what's the difference between atherectomy and IVL? With IVL, you are fundamentally changing the compliance of a calcified vessel. And that's really the problem with vessel preparation, which leads to improper stent implantation, is that we have a non-pliable sort of fixed calcified structure when these vessels get these significant calcium. And all atherectomy does is really shave that down. And in the superficial calcium, breaking up those planes can lead to some increased compliance. But really in these very thickly calcified vessels, there is nothing else that can really change that compliance outside of creating these microfractures to take down these planes. And that's really the difference here. You can see this on OCT here. You see this thick calcium here. You can see after IVL, these big fissures. And again, you can see how changing the circumferential calcium in these big planes through these big fissures, both on the macro and micro level, is going to change the compliance of that vessel. You can see how a stent is going to further expand these fracture sites and again, be able to be fully expanded and get those features we know that is associated with lower vessel failure rates. So we're going to go over a couple case examples to talk about where we have some unmet need and where IVL is going to meet some of those. So the first and foremost is this sort of idea of deep and thick calcium. Here's a patient who had a lot of symptoms tied up to medical therapy, inferior ischemia on a stress test. And you can see right here, that's a big, thick chunk of calcium you can see in the LAO and then on the REO. And you know that a burr is going to make a hole through here, but that's about it, right? We know that we're not going to be able to modify everything else as much as we want to. But regardless, we have to start out with a burr because we're not going to get anything through there because that's a 99% lesion. So we take a 1.5 burr, as you can see here, and then we have got angiography after that burr goes through. Still pretty tight, right? Because all we've really done is made a 1.5 millimeter hole through what's at least a 4045 vessel. You can see on OCT here, and again, if we were following our algorithm, we can't get the OCT catheter across before, so we know we have to drill in terms of following the algorithm. But here's where we see sort of that calcium start to come in, and you'll really see that lesion, because remember, it was focal. You start to see it come through right here. And you see, we haven't really done much of this thick calcium. We've created a few fracture sites, but that thick calcium remains. So we know we've still got work to do. That vessel is not ready for a stent yet. So we go straight to a 4.0 Ivl balloon here. We don't have to do any pre-dilation afterwards because the balloon's very deliverable. We then march it up and down because remember the emitters fall off a few millimeters off of each side. So we have to continue to work it up and down the lesion. We deliver all of our 80 pulses. And this is angiography after IVL. And it's amazing to see the angiography after IVL. That's the LAO and here's the REO. A little dissection here, but I mean, that almost looks like a stent-like result. It's pretty amazing. Look at the OCT again, and this really shows and illustrates the difference between atherectomy and IVL and the difference in what a vessel looks like and showing you what a truly prepared vessel with significant calcium looks like versus a vessel that's not ready yet. And we already saw an example of a vessel that's not ready yet. Look through here where the lesion was. We're getting ready to come to it here. You can see that calcium through there. And as we come up to that lesion, we start to see these big fissures coming through here. See these big fissures through the thick calcium that we simply didn't see before. We've got fracturing of all of these planes. And so now we know the compliance has been changed and it's ready for a stent. You can see here after stent deployment, you can see here in the REO, and that's a stent that's not going to fail. And this is really illustrative of the differences here. This is OCT after atherectomy. This is after IVL, the big differences, and this is why this technology is so different, and then full stent expansion afterwards. So let's move on to bifurcations. Again, this would be a lesion that we would be somewhat worried about drilling here. You can see there's some disease right here. Are we going to pinch that off? Is it going to go away during the drilling process? This is a big deal. This is actually a patient, again, significant ischemic burden, on optimal medical therapy, a lot of symptoms. He's also severely anemic, and we really struggled because we wanted to try and preserve this bifurcation, but we really wanted to try and do it with a single stent strategy here for this bifurcation because of the severe anemia and trying to use short DAPT here. So you can see here, we wired both and we performed OCT. And the really interesting part here as we come through is that we'll see the vessel downstream. And what I want you to look at, and you can actually see it on the longitudinal version here, here's the bifurcation. Look at this huge calcified nodule. And this is one of the challenges of calcified bifurcations is that trying to use a quote unquote provisional technique here, you know, if the ostium of the side branches is really calcified, it's going to be quite difficult to not have plaque shift here and not have that shut down. You can probe it, you can do all of these different things, but ultimately it's often going to end in a two-stent strategy. And look at that coming through that big nodule. Right now, we don't have a solution for that in order to keep this as a single stent strategy. So IVL had actually just become commercially available in the US, and we started with the LAD. You can see here, a very good balloon expansion result. We actually only used 60 pulses. So we actually then took it in there and just thought, let's try a provisional IVL strategy here. Got full expansion after 20 pulses there. What this illustrates is, number one, being able to keep the wire down the diagonal, and it also illustrates being able to use the IVL balloon in different branches when you're doing a bifurcation, and the deliverability of a balloon that's already been unwrapped, being able to deliver down. People often ask about the deliverability, and I think this case illustrates it quite well. You can see here this really nice result, particularly here in the diagonal branch here. IVL shows us that we're ready, or OCT shows us we're ready to go here. Single stent strategy here in the LAD. And this patient's got a lovely result and going to be able to have short DAPT. Did very well. Let's talk about large vessels. Again, this is one of those, oh my gosh, do I have to use an 8 French guide so that I can get a 2.0 burr, or maybe use orbital in order to get, use the larger circumference there at the higher speed. But again, we know that's associated with increased debris production, all these things. It's the left main. Am I going to shut anything down? No reflow, all these problems that we had to think about before, but IVL is starting to become a solution for. You can see that distal left main there. You see it there. You see it here in the spider. It's suspicious, right? We end up IVUSing that. We can actually see, we actually FFR'd it first and it was normal. Didn't like that. IVUSed it. Actually said, look at that. MLA is less than 4. And it's really interesting because it's truly isolated in the distal left main. It didn't involve the osteo, the LAD, or the circ. You can see here, the osteo, the circ, and the LAD are truly preserved, and it's truly right there, just a millimeter or 2 proximal to the bifurcation. So we had isolated left main disease. We had a heart team discussion. The patient said, I'd like PCI. So you can see a setup shot here. We ended up taking, because it's heavily calcified there, ended up taking a 4.0 Ivl balloon in, as you can see here. And look at this calcium, right? This is maybe 40, 50, 60 pulses in. Severe calcium, and that's not a bub. You can see here, we finally get good expansion there. We treated from the LAD back over, because again, we didn't involve the ostium and circumflex. What's really interesting here, this is my first unprotected left main. You don't usually see hemodynamic perturbations much. Sometimes when patients capture, you'll see a little bit of pulse pressure during, but not much. You can see here, this is before IVL balloon inflation. This is during, the T waves did jump up and the T waves came up, and you can see the pulse pressure came down. This is not from capturing from the IVL pulses. This is actually from ischemia. Patient had no symptoms. And what was interesting is this would occur about 8-9 seconds in to my 10 pulse cycle. Then about 5 to 10 seconds after the balloon inflation would come down, everything would normalize. And so we just kind of took our time a little bit more than we would have in a normal just non-left main setting. You can see here after IVL, looks lovely, a little bit of pinch of the circ. We ended up re-imaging there. You can see here calcium fractures as that wire comes in here in that distal left main, big fractures all through there on IVUS. That's a vessel that's ready to be stented. You can see here the ostium at the circumflex. You see there all those fractures, and that's ready. You can see here the ostium of the circumflex is still preserved. We decided on the single stent strategy here. Single stent from the LAD to the ostium of the left main. 4024 post-dilled, potted in the left main. You can see here on the right, a little bit of a pinch of the circ, so we FFR'd it. It's lovely. Re-imaged it, no big deal. So in conclusion, these lesions, these calcified coronary lesions are a frequent problem in today's cath lab, and we know they increase our paraprocedural MACE events for these patients. We can mitigate this with calcium solutions that we currently have. IVL is a novel calcium treatment solution in our bag of calcium modification tools, and particularly it can address some of the unmet needs in our calcium modification strategies. Again, these algorithms do exist. There's a very nice one from Optima, Sky, several different ones that are out there. We'll continue to see these modify as we continue to get more information about how to use these technologies properly. And again, I have to always say this in talks like this, always image. You'll wish you had a lot more than you wish you hadn't. Thank you very much.
Robert, that was great. Thank you very much. Now, it strikes me that quite often we have these conversations between enthusiasts, and even with that yellow tie, I can tell you're an enthusiast. So, but to get things over the line, technologies over the line, sometimes we have to have conversations with non-enthusiasts, or perhaps not just our colleagues, but sometimes management, structure, and so on. And of course, these conversations are important, and they all resolve around the why. Why do we need this technology? Why are we doing these patients? So if you were to summarize that, because you've already used this technology, so I know you've had those conversations, what got the technology over the line into your hands in such a successful fashion?
Sure. So this is not a simple issue by any stretch of the imagination. I think what it boils down to is, are there, the lesions that we were doing atherectomy before, we're still doing atherectomy. So that's not really going to change. This doesn't necessarily replace anything. What we had to talk about are really the essence of this talk. What are the unmet needs where we simply don't have the technology to meet the needs of our patients? And that was where we started looking at examples like we put on today, saying we simply don't have anything to decrease the periprocedural MACE rate for this population. We also had to look at cath lab efficiency and say, what is this compared to some of the other tools that we have in our toolbox? Because again, time in the cath lab is expensive, and we have to put that into play. We have to look at what complications cost. So it's both from a patient care standpoint and a healthcare delivery economic standpoint. We have to look at all of that together. So it's not a simple, well, this costs X amount of dollars and takes away from this procedural's net revenue. It can't be that simple. We have to look at the bigger picture of how we take care of patients, both from a procedural success standpoint, from a complication standpoint, and from an economic standpoint. Because again, if you focus on the micro, sure, yeah, this seems problematic. If you focus on the macro and put it all together and you use this technology responsible, then I think the conversation becomes much easier to have.
And Robert, of course, it's slightly analogous to the CTO environment, which I know you're familiar with. And the analogy we use sometimes there is bus routes, that not all bus routes are busy, but the busy ones actually keep the ones that maintain the network in business, because you run the volume through that. And the other kind of discussion I wanted to have with you in terms of the lithotripsy side of things is it's a value judgment. The problem that we're having is that the value is different in the eyes of different stakeholders. So the ultimate stakeholder is the patient, and the question they're asking is, what value am I going to have from this intervention? And as physicians, we have to answer that in not just monetary terms, but in terms of quality of life and reduction in cardiac events and ability to play with their grandchildren, or whatever that value may be. But sometimes that metric is taken out of context with health in terms of healthcare economics. It's just upfront price versus the comparator product, for example.
Yeah, I think, gosh, it's hard because you want so much to just keep this focused on the patient, because that's the way it should be. The world's gotten a little bit more complicated for reasons that, that's a different conversation. But if you do boil it down simply, I remember when we first had the first patient coming through the Disrupt CAD3 study, we had the first patients coming through and you had to sit down and say, I had to talk about why should we enroll in the study? Why is this potentially a value? And what it boiled down to is, I could say, look, based on what we've seen, we know we have to use a calcium modification strategy. You have a severely calcified lesion that's indicated and you want us to fix it. We have these different technologies that have certain major adverse event rates, including everything from guide choice to access choice to all these different things, even in terms of atherectomy versus IVL. I have a technology that's going to make this simpler, more efficient, and with an extremely low periprocedural major adverse event rate compared to other things. It's really easy for a patient to say, oh, well, if it's going to make my procedure safer, well, then certainly. Now, what I can't answer at this point is long-term outcomes, right? Do I know for a fact that a year from now, 2 years from now, their major adverse event rate is going to be different? I can't. But what the patient wants to know is, when I come in for my procedure, what's that look like? And we were able to answer that pretty cleanly.
Yeah, and I don't think we should ever be scared of that why, Robert. Ultimately it drives behavior. And one of the metrics you mentioned, of course, was the technology you use. But of course, how you use that technology is also incredibly important. And Peter, we touched on this already, that actually that informed consent process should be some sort of honest explanation about who you are as a physician, your understanding of what you're about to take on and how that might affect the outcomes. Is that something that you would kind of take into play with a patient that is about to have some form of calcium modification?
I think that's a really good point. I think it is something which you should discuss with the patient, because There are ways to get from A to B, and I think you have to make sure you're adequately resourced and equipped to be able to do that case, because you've got the technical skills. You've got to make sure your cath lab has got the technical ability, your team is working. But these are all discussions for every case we do in PCI. I think it's really relevant, because then there are always alternative therapies, either drug therapy or even bypass surgery. So I think you've got to put all those things on the table and try and give the patient the most informed consent you possibly can.
Sounds like it's going to be a long chat.
It could be a long chat, but ultimately, I think if the patient at least leaves that, and often it's not the patient, it's often the family that's the most important to get it across to, because if there is an adverse complication, it won't be the patient you're necessarily talking to. I know it's a horrible thought, but it is a reality when you're dealing with these types of complex lesions. And I think Robert's shown some fantastic cases. And what I really liked about those cases was making, complex things very simple, and that's what IVL has done. But the alternative to using IVL may have been to go through many different other devices and spend a lot of money on other equipment. And of course, people don't always take that into account. And they don't always take into account the alternative of bypass surgery, which will cost a lot of money, but is not necessarily compared against PCI. So I think it is really difficult to get the metric right and to understand the measurement.
And that's a classic mistake that we make from a psychological perspective, Robert, that we measure the impact of our intervention, but we can never measure the impact of a non-intervention, so that's something that's never easy to measure. But having said that, Robert, a great talk, very eloquent summary of actually the future of IVL in terms of its practice. Now, how would you summarize that in terms of it? Is this going to be a small iteration to your practice, or do you see this as a kind of more broad-ranging in its impact?
So, a bit more of a difficult question in the US because of the economics, because it's not just as simple as what is the best thing in this situation all the time. There's so many factors that go into that. But if you make all things equal, what this has done for the practice is significantly simplified previously complex procedures. I love what was just said of all the cases that I showed took things that you've got to really think on. You've got to have a plan in place. You've got to be able to bail yourself out relatively easily from some potentially, whether it's side branch loss or dissections or no reflow, all these different things. And then you've got to have, if my 2.0 burr doesn't necessarily shave that left main the way I want, am I going to take a 4.0 cutter? All these different things. It made things so much simpler. And so I think it is practice changing in the sense that a lot of these more complex procedures are going to become simpler. Now, does that mean that as a complex operator, I am going to be potentially out of a job at some point? I hope not, but I do think for a lot of people, this is going to significantly simplify the practice of patients with complex anatomy. And that's a reality we all have to face. We know people's anatomy continues to become more complex. Their physiology continues to be more complex, and we have to continue to evolve, not just the CTO operators and the chip community. We all have to evolve because these are our patients, and we have to continue to figure out better ways to take care of them. And if we have a technology that is going to simplify that and make things more simple, well, of course, we're going to gravitate to that. So I do think for those reasons, it'll be practice changing for me personally.
Yeah, actually, Robert, about the job, I have got some bad news about that. Maybe now is not the time to break it to you, but I mean, actually, we had Bobby Ye on earlier, and the phrase he used was democratization of the treatment of calcific lesions. And actually, I think that's the way to look at it. And that means, I think, to flip it, the complex argument on its head, it means supporting people who aren't used to complex environments. And I think actually there's always going to be plenty of cases to keep Robert Riley in a job. But at the same time, what you're going to have to do, I think, you and Peter and those of us who work in the complex space are going to have to support more broad-ranging educational endeavors such as this to support people who aren't used to that environment, where everything doesn't go to plan the first time, but who have got a technology which actually will open up access to successful treatment to a lot more patients. So with that in mind, I'd like to thank you for your time today and your excellent presentation. And obviously, you're actually back with us on a later webinar performing a live case. So very much looking forward to that. Thanks for your expertise and your engagement, and hope to catch up soon.
Again, thank you guys so much. It was really an honor. Thank you.
Thanks very much.
Please join us next Friday, the 30th of April, for Class 2, an introduction to coronary IVL. This will be chaired by Jonathan Hill and will feature an interactive live case from San Carlos Hospital in Madrid with Javi Escanad and Nieves Gonzalo. Jonathan will also be talking on the basics of IVL and Benjamin Faury on the subject of intravascular lithotripsy techniques. Thanks again and goodbye.